Hi there, so Dr. Peters, I'm going to be doing a quick case study on hypovolemic shock. Your discussions this week are on different types of shock, so I'm just going to do a uh, brief one, go over what happened. So we have a 41-year-old that was in a car accident and has a lacerated spleen and bleeding through an open wound. This patient was immediately taken to the OR, and it looks like 1,500 mLs of blood loss is replaced. So think about this patient, what's going on, and we're talking about shock. All right, so this patient, obviously, in order to get the patient to surgery, you need to stabilize the patient. So you're always going to be thinking ABC. So you're thinking airway, breathing, circulation. So do they have oxygen? Are they getting oxygenated? You want to make sure their organs are being perfused. And then you think circulation. So if this person's lost a lot of blood, you're going to be giving them a lot of IV fluids. So you get this patient stabilized enough to get to surgery because this patient has to have emergency surgery. And let's say he had a splenectomy because his spleen was ruptured. So post-op assessment, his temp is 99, heart rate's 102, respiration 22, and blood pressure is 108/60. So the patient's a little tachycardic, respirations are a little up, and has a low-grade temp, which is probably to be expected from the stress. Look at the other symptoms: lethargic, yet oriented ×3, skin is pale, cool, and clammy, mucous membranes are dry and light pink. At this point, the patient's NPO, there's an NG tube down, and there's about 50 cc's of greenish fluid. And the patient has 0.9 normal saline going at 125 cc's an hour. So when you look back at the patient scenario, the patient case, does the patient initially have actual or relative hypovolemia? So we have to know what both are. What is the difference between actual and relative? Well, the easiest way is absolute, meaning like you absolutely lost blood. So it's usually blood or body fluids that you've lost. And this can be, such as this case, you lost blood because the patient had an open wound and he's actively losing blood. So you're going to lose blood volume. You absolutely lose volume, period. Other scenarios could be diarrhea. The patient can go into absolute hypovolemia because they've lost so much. Or what if they have a lot, there's 50 cc's coming out of that NG tube. So they already have this patient already has absolute hypovolemia, but could also have it compounded if he starts putting out, say, 1,000 cc's from the NG tube. So it's really, you have to really watch that. Relative hypovolemia is more so inside the body. You haven't necessarily lost blood outside the body, but inside the body. And it's due to increased preload, increase in the capacity of blood vessels, and it's an increased capacity of blood vessels to sequester blood volume away from the heart. And for example, shock with vasodilation. So what happens is blood actually, or fluid, shifts into the third space. So when you think about cirrhosis, patient with ascites, where is that fluid? So the patient is hypovolemia, but it's more of a relative because it's something that's happening inside the patient's third spacing. That patient gets treated different than an absolute. There's always a gray area. There's some people that can have both absolute and relative. Another slide here just to show that absolute results from fluid loss, which we mentioned, GI, also some drainage, the diabetes insipidus, hyperglycemia, and diuresis. Thinking you are losing volume. If you have hyperglycemia, you're going to diurese more. Relative, fluid moving out of the vascular space and into the extravascular space. So that's the third spacing. You have vasodilation. So what should initial treatment include for this patient? We talked about this. ABCs: oxygen. You're going to increase the IV. If this person, this initial person that came in with this motor vehicle accident, you're going to have probably the fluids going at the highest possible because you want to bolus them and make sure that they're getting that volume back. This patient probably got a blood transfusion also, I think it did say that it did transfuse. So for every gram of hemoglobin is 1 unit of blood. So let's just say they did a CBC and the hemoglobin is 7, then they'll probably get 2 to 3 units of blood to just get it up to 10. And you want to make sure that that patient's not losing blood, which is why they immediately go to surgery. So airway, circulation, airway breathing, oxygen, circulation, IV. So we're thinking about priorities. Assess for bleeding post-op because now they're going to have an incision. And so you want to assess for that bleeding at that time. So you continue to assess, and 3 hours later, you determine the treatment has been affected. So what do you suspect you observed? So what are we going to see as an improvement? Another thing to look at, if you go back to priorities, this patient's going to have a Foley. So we're looking at I's and O's output. This patient's NPO, so we're really looking at output. Intake is going to be fluids, right? So looking at intake for IV fluids, what's coming out? Does this patient have good urine output? And make sure that there's something coming out of the NG tube that's not excessive. Why does the patient have an NG tube? Well, we want to reduce that gastric secretion. The patient just had a splenectomy. We don't want nausea. We don't want aspiration. So we want to minimize that as much as possible, gastric secretion. So this is what we're going to expect. As the patient's improving, the heart rate was a little tachycardic. Now it's down to 90, and this is just roundabout. I wrote these in here. Respirations are 20. Blood pressure is 128/78. So it looks like the patient is stabilizing. The patient's not as tired. The skin is not pale anymore. And the urine output's good. Another thing to really add in here, again, is priorities. So what is the oxygen saturation on this patient? So when you are looking at a shock patient or any patient in general, you're thinking, is this patient compensated? Before, the patient was decompensated, as you can see, and it could have been worse with the vital signs, but that was post-op. We did not put a scenario of what the vital signs were before, but I would almost bet that they were much worse. All right, so that is a example of post-op. So what are going to be your priorities? Oxygen, increase the IV, and you're going to assess for bleeding. And that is it.